alaikum. I'm Dr. Tahira and you're watching Health is Wealth on PTV World. In matters of the heart, one has to be very careful, especially if it involves mending the heart. It has to be in the right place, in the right time and in the right hands. Today we are here with Dr. Tauqeer Akbar, who is a cardiac surgeon, and we're going to talk all about cardiac surgery. We are present here today with Dr. Tauqeer Akbar, who is a cardiac surgeon, and we're going to ask him all the questions we need to know about cardiac surgery. So, Dr. Saab, thank you so much for joining us today. First things first, what is the difference between a cardiologist and a cardiac surgeon? Because I'm sure a lot of people out there are really confused that if something happens with them, for example, they have a heart issue, who do they go to and when do they go to?
Okay, I think let's just dissect this into maybe split that question into two. We should, who is a cardiac surgeon? Cardiac surgeon is a surgeon who performs procedures on the heart and the blood vessels within the chest cavity. The difference between a cardiologist and a cardiac surgeon is when, let me just put it lightly, where cardiologist stops, cardiac surgeon takes over.
Right.
So essentially, it's the no-go area for the cardiologist. Again, no offense to my cardiology colleagues, but that's.
But you know, when we talk about a cardiac surgeon, I think you're the ones who are the actual lifesavers. You know why? Because especially in cases of emergency, for example, if somebody is suffering from an MI and they run to the hospital, then it's the intervention that saves them at the moment. For example, a cardiologist would probably give you medication to have your heart disease and your hypertension and coronary heart disease stable or controlled, but when it goes out of control, then you intervene. So whenever we rush to the hospital, this intervention from a cardiac surgeon, what does it mean to the patient?
Okay, let me just again correct that a little bit. It's the cardiologist has a vital role in the management of myocardial infarction.
Yes,
they
stabilize the patient,
and they perform the initial management. So either they have to thrombolize the patient, which essentially try to dissolve the clot within the blood vessel, or maybe perform what's called a primary coronary intervention. They are the ones that perform that. But even in case all that fails, then in that acute situation, cardiac surgeons take over. And then
so when you speak of cardiac surgery, is it the angioplasty or is it the coronary artery bypass surgery alone that you're going to do?
In this context, it's coronary artery bypass surgery. So angioplasty or PCI, a percutaneous coronary intervention, is performed by a cardiologist. It's a procedure. But once it involves an incision, then it becomes surgery, and then it's the cardiac surgeon who looks after that aspect of patient care.
So when we talk about CABG, it's very scary because people think they're going to put you on the table, rip open your chest and your heart is going to be out and there's going to be so much of blood loss and it won't heal and so on and so forth. So could you kindly, clear this for all the people out there who are very fearful of these surgeries and keep delaying it for one reason or the other?
I'm glad that you put it as that caricature, and I tell you from my experience of talking to the patients that that's not a very unusual presentation. I mean, the impression people have is as if somebody is going to rip open their chest and then they're going to take the heart out, they will put it on a bench, maybe take out a screwdriver and fix it and then put it back in, and you don't know whether it works or it doesn't work. No. It doesn't happen that way. What we do is we have to actually have access to the heart. We can do that from the front or the side of the chest. Okay, and then and there isn't much of much to choose between all these different ways of doing. So just to keep the matters simple, I'm just going to talk about accessing the heart from the front. There is a breastbone right in the front. So we split that open in a very controlled fashion, just limiting the incision as much as possible.
And how's the surgery changed from before? Because in the past there used to be a very massive incision and you used to see stitches all across
so
how has that changed?
We have reduced the extent of the incision, and we have started accessing the heart from the left side or the right side of the chest, so that you don't have just
one incision, one big incision.
One big incision from the neck to the belly button. No, it doesn't happen that way. It is from there, from the angle of that breastbone to just where it's about to finish. So it's just that small incision, so that if you have a collared shirt and you button up, you will probably not, nobody will notice that incision is there.
And this bypass grafting is from some artery or blood vessel elsewhere. Previously it used to be from the thigh and all of that. So where is it from now?
Yeah,
and how, from where do you take it from?
They are coronary, they are internal mammary arteries on both sides of the breastbone, one on the left and one on the right. In addition to that, there is a spare artery given on one of the aspects of the forearms. Okay, so these are there are other vessels that can be harvested, but these are arteries. So basically, we're going to replace arteries with arteries. Now, of course, there is a role for the veins, for us to use the veins.
Oh, okay, so you can use the veins
we
as well.
still use the veins from the legs, and what we found is that there was a lot. There was a massive trend towards doing arterial revascularization. But what nearly a decade of research has demonstrated, that with the current medication, there isn't much of a difference between
vein or artery.
Vein or artery. So we've kind of our threshold for using the arteries on. I mean, if I'm doing surgery on a young person, I will want to prefer. I will want to use the arteries because I want to use the arteries because instinctively I think its long-term patency will be longer. Okay, so that's why I want to use it. But in a case of an emergency, I will want to use one of the arteries and want to use a couple of veins to try and get that procedure done as soon as possible. So
when somebody has coronary artery disease and they have atherosclerosis where there's cholesterol or any sort of thickening or narrowing of these blood vessels, and then all of a sudden it stops, the supply stops and you get an MI or you get a stroke. They go to the doctor, they perform all the tests, preliminary tests, an angiography, and then they say, oh, the stent is enough. We have put the stent with the angioplasty and it's enough. When is it, how much, like in the percentage would you say that no, a stent cannot cover this and now they require a cabbage, and is that immediate or is that after a while? So what is that, that number that you would say?
No, just as a rule of thumb, if you are requiring more than one stents, then you would want a heart team to make the decision. That is the recommendation of the American Heart Association, and this is what should be implemented.
Are we following that?
Unfortunately, we don't, because we love shortcuts.
And we have
So it has to be a heart team's decision that this person needs coronary revascularization. That is, I'm sorry about the terminology, okay? They need to have new blood vessels
Planted in there.
implanted in them,
Right.
okay? Or they need to have something done to their blood vessels, okay? To restore blood supply.
And for a longer,
okay?
more,
Yes.
sustainable
Yes.
outcome.
Yeah.
So how long does this surgery take? What are the precautions for this surgery? Who are the people who are fit for this surgery and who do not qualify for this surgery in terms of, if somebody is diabetic, severely hypertensive or something like that? And then and how fast can they come back to normal life?
Yeah, that's an excellent question. I'm glad that you've hit the nail on the head. It's the patients who require coronary bypass surgery as against coronary intervention or stenting is patients who are diabetics, who have diffuse disease, who have impaired cardiac function, or who are elderly.
All right.
They, yes, young people will require, I would recommend they should undergo coronary bypass surgery because bypass surgery is more likely to prevent progression of the disease because coronary artery disease is not a static condition. It is a progressive dynamic condition that is going to progress in life. So our objective should be, as patients or as physicians or as surgeons, should be how am I going to modify the progression of this disease? And the easiest way to prevent progression of the disease is when I control the risk factors and then I do an intervention, a procedure that is more likely to last longer and that is more likely to prevent or slow down the progression of the disease.
And how long does the patient stay in the hospital?
Thank you. That question as well. Routinely, my patients will, after their surgery, we take them to the intensive care and we observe them for three main things. The main thing is to make sure they are hemodynamically stable, that is their blood pressure is good and their heart rate is okay. Their oxygen level is satisfactory and there is no bleeding. And once those three things are fine, then we wake them up. Within 1 or 2 hours of their surgery, depending on the complexity of the surgery, they will be awake and we will then be monitoring them. Maybe after a few hours, we can actually sit them out in the chair. In fact, in my intensive care, I would expect my patients to be on the morning round, to have had their breakfast, sitting in a chair. That's how I measure my nurse's performance. Okay, so that's and this is a team effort. It's not just me. It's an entire team that has to work in a very coordinated way, have confidence in each other's abilities, and then and now somebody who's had their surgery yesterday we will want them to be up and about today. They should be, by about day 4 after surgery, they should be self-caring. They should be able to get in and out of bed without any support, walk around without support. In fact, we get our physiotherapists to get them to climb the stairs so that they have the confidence to be able to climb the stairs, because these are the common questions that
can we climb the stairs? Yes. How much can we walk?
The other thing that after coming to Pakistan I realized that we have to emphasize is the dietary restrictions. After surgery, we tell people that any dietary restrictions should be observed by the family and not by the patient, because they lose their because of there's loss of appetite. Somebody who is used to eating, and good tasting food.
So how much exactly should the diet be in terms of calories, number one? And number two, what should the diet include? Like it should be exclusively no salt diet, no trans fats, no meat, or it can have everything in it, but in moderation.
In fact, I insist that no dietary restrictions on my patient.
Oh, wow.
The only
Lucky
dietary
patients.
restriction, the
Is
only
salt
diet-
and
is
oil?
no, the only dietary restriction is sugar.
Okay, so
The
that's something
only
new.
dietary restriction for my patients after their surgery
It's sugar.
is sugar.
And we keep
That's
thinking that heart has nothing to do with sugar. You know, we always think heart, okay, oil, heart, maybe, salt, but we never think of the sugar part of it.
No, it's because, you see, for us, a good glycemic control, blood glucose level control is very important for us for the healing of the wounds. So that's why my emphasis is on avoiding sugars and controlling patients' blood glucose. We have our own way of managing the blood glucose in the post-operative period. It's a lot more aggressive than the way our physician colleagues manage the patient's blood sugar.
And what about, for example, if a patient is obese, do you actually wait for the patient or put them on a weight loss plan first before the surgery, or you just do the surgery and then put them on a weight loss plan?
Unfortunately, I remember, just from your question, I recall that I used to be involved in a cardiac transplant program elsewhere. And whenever we sent a patient to dietitian for a weight loss program, they actually gained weight. And we found out they were saying, okay, only 2 biscuits with the afternoon tea. In the UK, it's afternoon tea. So they were having digestive biscuits.
Yeah, the big ones, right?
Normally what I do is we have to be realistic, okay? As physicians, we are here to help patients, not punish them, okay? There are patients who will be obese, and and because of their ischemic heart disease, because of their angina, they can't actually exercise. There is a limited scope of their improvement in their weight.
Right.
Okay. Yes, we do tell them to restrict or reduce their smoking or try and lose weight. But if somebody has ongoing angina or has angina on minimal exertion, then we've got to get on with it and deal with it,
And what kind of exercise regimen do you advise them? How much of walk is okay for a post-CABG patient?
Post-CABG, I'll just tell you about the physical activities right from the, like I said, we get them out of bed. And then second, third day, we get them to climb the stairs. Okay. And then after that, I normally tell my patients just to restrict their activities to walking around at home, maybe doing a flight of stairs at home for the first week. And we normally see them back in our clinic after a week. And now, at that stage, I insist on my patients to start to interact with, socially interact. And if for them, I would normally tell them, you should go to the mosque, go and say your prayers in the mosque, okay? And it doesn't mean that 3 people should carry you.
And he should be mobile.
They should be able to go walk
on their own.
And they do some stairs. Okay.
Right.
Okay.
And what about the wound care? Because infections here are very common, wound dehiscence is very common, then they have all sorts of pain, phantom pains coming up. So how do you deal with these conditions, and how do you advise them post wound care? And also one more thing, since they're on blood thinners after that or different kind of medications, what are the precautions they need to take with that?
Okay, wound care. Okay, So wound care, you don't have to put all sorts of medication and with. Actually, I tell my patient, if we've done a fairly good job of actually putting the wound together, and thankfully we've very good cosmetic result, then they should, that wound, by the time the patient is interacting with the public in about 10 days, 12 days after surgery, they should actually, that wound should be well sealed. Okay, you don't need to cover the wound. Okay, you need to keep the wound clean. They can have a shower. They can and just dab the wound, not just scrub it. Yeah, okay. You don't need to do that. Right. Just dab the wound, clean it, keep it clean, keep it dry, and if you can keep it exposed to the air, that helps in healing the process as well. So keys to wound healing is actually blood sugar control and keeping the wound clean. Right. Okay. Now, as luck would have it, in one of the hospitals, that one major hospital, I will not mention the name, but when I came to Pakistan, we strictly adhered to the NHS, National Health Service protocols in the UK, which is antibiotics for 48 hours and we will stop antibiotics. And some of my colleagues who trained in Pakistan, they were continuing antibiotics
for a very long time.
Yes. So a few years later, 7, 8, 10 years later, one of my intelligent medical officer asked me, should we do a comparative study on these two sets of patients?
Exactly. For AMR as well?
I said, yes, and you have my consent? Yes, I would. In fact, and what we found was that the wound infection rate was higher in the antibiotic, indefinite antibiotic group. And this is in keeping with the observation in the West. So despite all our impression that Pakistan is different, no, it's not different. The same rules apply as the rules elsewhere in the world apply. So antibiotics, it's like we can't take away our responsibility to make sure that our procedure, that our equipment is right, okay, it's well sterilized, that our practices are satisfactory, up to the standard, our post-operative wound care is good, our blood glucose control is good, and we have informed the families on how to look after the patient afterwards, and then the follow-up care of the patient. So it's a package.
So Dr. Saab, we've been speaking a lot about coronary artery disease, but a lot of people have valvular issues, and we often have this, there's a tricuspid, bicuspid, pulmonary valve failure, or there is, some kind of terms like mitral regurgitation and all of that, right? So what exactly is this valve thing? Like, it controls the direction. How does it fail? How do you repair it? How extensive is this surgery, and what is it called? A valvular repair, what is it called?
Okay, now there are 4 valves in the heart which control the direction of flow of the blood within the heart. On the right side there is the tricuspid valve and the pulmonary valve. Basically, the blood flows from the veins into the heart, into the right atrium, and from there through the tricuspid valve into the right ventricle, and from there into the pulmonary artery and into the lungs. On the left side of the heart, the blood comes from the lungs into the left atrium, okay, and through the mitral valve it goes into the left ventricle, and from there it gets pumped out into the aorta through the aortic valve. Exactly. So those are the 4 valves. Yes. Now, in Pakistan and a lot of the developing world, there is a very high incidence of what's called rheumatic heart disease, yes. Rheumatic valvular disease. Okay. In addition to that, there are infections of various types affecting the heart. And these patients, they present earlier in life. And in Pakistan, there's a significant incidence of congenital valvular disease, yes. As well. Okay. And then we move to as we age, the population, the degenerative valvular disease then come into play. So people tend to develop calcification of the aortic valves or the mitral valves, you know, and those are the kind of valves diseases that happen.
And how do you repair them via surgery?
Yeah. Generally, there are 2 ways of dealing with the valves. Okay. One is to repair, and the other is to replace the heart. Now, on the mitral valve, we can repair the valve, the leaflets of the valve. Basically, you see the leaflets, yes. You know, like the one with their flap. Yes. Yes, they have to meet like this. Right. Okay, so we have to make sure that is this surface. If they were meeting, they were not meeting in the middle. They were going. We're going to bring them together. Or we have to augment this, or maybe prevent it from prolapsing. Okay, so that's one way of.
And when you talk about replacing the valves, is it something artificially that you're going to
we can replace the valves with tissue valves or with mechanical valves. Mechanical valves they're not metal valves; they are made out of carbon. Okay, and unfortunately, in Pakistan, the availability of tissue valves is a problem, because they have to maintain a cold chain, and maintaining a cold chain, and most of the companies can't guarantee a cold chain, and because of that, we are always worried about the quality of valves and how we source our valves. So tissue valves are problematic. In Pakistan, vast majority of the valve replacements are actually mechanical valve replacements. Now, the downside of mechanical valves is that you have to thin out the blood, for the rest of the patient's life.
Okay, so they might have bleeding issues.
Tests. They have to have tests done often to make sure that the blood is thinned out. Yeah, of course there is always risk of internal bleeding, and in fact we screen the patients for any coagulation or bleeding tendencies, or if.
And how long do these last? These carbon valves?
Actually, they last theoretically
better
last
a
lifetime.
Oh,
yes,
that's very
yes.
good. So there's no chance of them, like, you know, of saying that the carbon valve no longer works.
Is worn off.
Oh, it's worn off, so it doesn't.
It's very
That's
unlikely,
very,
very unusual, unless there was a problem while implanting the valve.
But you said that the causes of these valvular diseases, so for example, degenerative with age, so that works. But if the cause is genetic, or for example, it's a rheumatic fever that was caught, right early in life, so it's a child you're dealing with. So in case of children, so what is the mechanism? Doesn't the valve grow? It has to grow with the size of the heart, right? So then how do you do that?
That's a problem especially with the aortic valve, because the aorta has to grow with
time to pump more and more blood for the rest of the body.
So there are various ways of dealing with that situation. Where our preference usually in that kind of situation is to try and dilate the aorta from time to time, okay, and wait for the child to grow.
All right.
Okay.
And then delay the surgery
And then
till
delay
then.
the surgery. Okay. Now, if we can't do that, and there are circumstances you won't be able to do that, in that case, what you could do is rather quite an aggressive procedure, which is basically you take out the pulmonary valve, the connection between the right ventricle and the pulmonary trunk that takes blood to the lungs. You take out that
part.
and put it in place of the aorta,
Okay.
and then replace that.
That's a very aggressive procedure,
Yeah,
though.
that is, so, but I mean, it's got to be done.
procedure?
It's not commonly done, but if it's called the Ross procedure, it's got to be done. It's got to be done, and someone's got to do it.
Well, it sounds very
Yes,
scary.
it's,
What
it is.
about the very common foramen ovale or patent ductus arteriosus that they say that a child is born with a hole and there's mixing of the blood, the pure and the impure blood, and the sooner it needs to be closed, the better. What do you do for that? And there's one more question. This is a little, it's not very common, but I wanted to ask you. For example, I had a friend who had a very bad migraine, and she was diagnosed by someone, which was very strange, that she has a patent ductus arteriosus that was causing that headache, and then she had a flap closure and it actually worked. She stopped having those headaches. So could you please shed light on this part of
Okay,
heart
now
disease?
a patent foramen ovale and atrial septal defect.
Yeah.
Okay, that can be treated percutaneously. My cardiology colleagues can put a wire through. They can, but it has to be. They put in an umbrella-like device. They're like two. They're kind of two umbrella-like devices. Okay, joined to each other. They put it in through the hole and deploy that. And so that hole is there, and there are two kind of umbrella devices kind of holding that. But not everybody, not all the patients will have a defect that will be able to be
fixed
closed
by that umbrella.
with this device.
Okay.
So if the margins are not adequate, then we will have to. So, and again, no offense to my cardiology colleagues, where cardiology stops, we have to take over, and
But how
we have to
extensive
fix
is
it.
this surgery? Like, and what age should a child go for it?
I think normally for atrial septal defect, a child, a preschool child should have that fixed. Okay, and the child should be able to go home within 3 to 4 days of surgery. So it's not not a massive operation. Yes, it sounds like, oh, we're going to open the chest, or we are going to repair a hole within the chest, within the heart. But fortunately, we've loads of experience of doing this, and we've excellent results from that. And that's
what
not
about
something
arrhythmias and pacemakers?
Sorry, I'll just answer your PDA question. Again, there are ways of closing that with a device. But sometimes we have to make a small incision on the side, and we have to close it surgically, and it's easily fixable.
All right. So these were all the structures where the blood flow and everything was involved. But when the electrical circuit of the heart is involved, and there are arrhythmias, and there are all sorts of problems like Wolf-Purkinje and all of that. So then do you play a role in that or not?
We do play a role in some of that. But they are electrophysiologists.
Oh, that's a separate entity?
Yeah, it's a separate specialty.
So they're the ones who do those cardioversions, and then they're the ones who place the pacemaker as well?
Pacemakers
or you don't place the
and
pacemaker?
ablation. We, as surgeons, most of the in the congenital group, in the very small kids, we would place pacemakers surgically. because they are performed slightly differently. Otherwise, the electrophysiologist will put in a transvenous, the catheters or the leads transvenously. So that's what.
So what about the stroke prevention with cardiac intervention? There's this whole new dimension where they're trying to prevent stroke via cardiac intervention or something of that sort. Do you deal with that part as well? Or you
No, it's stroke prevention through that I think I would leave it in the domain of the cardiologist, but generally it's through anticoagulation.
They said they're doing it some kind of shunting. That's what I'm talking about.
No, you're talking about carotid artery stenting.
Yes, stenting, exactly.
Carotid arteries and arterectomy or
yes, exactly.
stenting.
I'm talking about that.
I leave it to my radiology, interventional radiologists or endovascular surgeons to deal with that aspect, and there are various ways of dealing with that. The carotid arteries are the arteries that take blood from the arch of the aorta up to the brain, and they can deal with that like in the case of the coronary artery disease. They can put in a stent, or they can deal with it surgically as well, make a small incision, then and then expose that vessel, shell out all the rubbish out of it, and put it back together. Excellent, very nice work.
And what about aneurysms? Do you deal with aneurysms of the heart and the aorta?
We do.
So could you kindly describe exactly like how an aneurysm presents, and is it an emergency, and like how do you go about it?
I think generally aneurysms, vast majority of aneurysms present with history of shearing pain in central chest pain. I'm just kind of trying to restrict myself to the cardiothoracic aspect of aneurysms, or or people can have pulsatile swelling in their abdomen, but that will go more in the vascular domain, and sometimes pain in between the shoulder blades. So those are some of the presentations of what's called an aortic dissection. So that is an emergency situation, and that person should go to a good hospital. Okay, you have to have a very high index of suspicion of the, or sometimes people who've come to who were involved in an accident or who have fallen from height, where there is a what's called a rapid deceleration, then there could be disruption of the aorta because of that. Okay, so it's an area that I've kind of specialized in, aortic surgery, and we've
so you keep removing these aneurysms on a regular basis and fixing.
We do.
What is the coarctation of aorta? What does that mean?
Coarctation of the aorta is on the descending on the beyond the arch of the aorta. Okay, so it is a narrowing, and it is usually it's by birth.
All right, so you can fix that as well.
Yes,
I'm
congenital.
I'm
congenital. In fact,
so you're fixing all of these things, the matters of the heart. So the real heart fixer or heart mender is you. Okay, Dr. Saab, people are very, very scared in Pakistan due to a number of reasons. Number one, not many doctors are specialized like you are, so they really don't know how to differentiate. And number two is the cost, because the economic standards of the country are obviously not up to par with the rest of the world. So how do you describe the costing of these procedures, and how would you, actually tell the patients that it's better to, invest in these procedures instead of not, and then delaying, and then, going that route?
Yeah. It's very important that one, Unfortunately, all the consumables that are used for most of these surgeries, they are imported. As the currency value fluctuates, the cost of all these items fluctuate. So that's why we have to always take into account. So if someone is telling you that I can do this on the cheap, then then something
it's
is
wrong
amiss.
somewhere.
Something is amiss.
Right.
Okay. So it's important that we always look for good quality institution and a good operator. Okay. At the end of the day, it's all in the hands and of course in the head. Okay, so that is not something that you will be able to display on a billboard somewhere. Okay, so as I often say, my patient, a live patient, is my testimony to the quality of my work. So.
We are present today with Dr. Tauqeer in his cardiac intensive unit, and here is where the patient comes right after the surgery. And Dr. Tauqeer, I'd like you to explain to our viewers a bit about what is it that happens in the cardiac care unit after that. For example, once a patient is here, what all is monitored, for how long do you retain them here, what are these machines, are they on the ventilator, are they on these monitors, do they monitor oxygen, what is it that's going around?
Yeah. Patient is normally transferred to the intensive care unit after their cardiac surgery. They are here. They have the invasive pressure monitoring going on that monitor.
So, and it's 24/7 they're being monitored.
Their oxygen level, their blood pressure, beat to beat, and then their heartbeat is being monitored. Right. And mostly they are on a ventilator, which is the device right beside you. So they are on, and like I said, they would normally be observed in this setting for a short while, just to make sure their blood pressure is adequate, their oxygen level is adequate, and there is no bleeding. Once those things are sorted, they are taken off the ventilator, and then we would normally be able to start mobilizing them, and depending on
so
how
like
well
you mentioned, it's usually 3 to 4 days a minimum that they are retained over here. That's for a minimum.
We normally retain them in the intensive care unit maybe 24, 48 hours. Okay. After that, they should be able to go out to their private room or the ward.
The reason why I'm asking this is there are a lot of hospitals out there, and you said the right selection of a doctor and a facility is very important. For example, after such a detailed procedure, how important is it to have a proper intensive care unit in a tertiary hospital, so that, you know, in case of any post-op complication, one can be taken care of?
Absolutely vital. I mean, there are standards of care that have to be, like they say, there is many a slip between a cup and a lip. Right. Okay, so I always, wherever I work, I make sure exactly the same protocols are observed as in the National Health Service, which I worked in for nearly 20 years, and they're kind of part of my.
So we're very fortunate, Dr. Saab, that 20 years of services in the NHS that's what you have gotten here in Pakistan, in Islamabad, and people here are coming, and as I see, there's a lot of medical tourism. People are coming from all over the country. Just we saw a patient of yours right here. So how would you, yes, from Afghanistan, and how would you describe this? You know, the moment they come here, they get treated, and they're all well, and they leave. You must be feeling such a sense of satisfaction. And are you planning to move back as well?
Yeah, I'm planning to be in Pakistan. I've been in Pakistan
coming and going, but now
coming and going, but inshallah I'll be based in Pakistan on a longer term basis. For our audience, especially in the United Kingdom, for instance, I mean, it's you can actually experience exactly what you would do in any of the good NHS setups with exactly the same processes and procedures in place to look after your loved one in Pakistan. So at a fraction of the cost.
Thank you so much. Thank you so much, Dr. Tauqeer. So you heard it from Dr. Tauqeer himself, the cardiac surgeon from NHS, that if you want a really proper cardiac intervention, cardiac surgery, state-of-the-art facility, sterile conditions, a very good doctor, all the hospital is clean, neat, and follows all the standard protocols for a fraction of the cost, and without having to wait for any appointment, you can have it right here in the heart of Islamabad. Thank you so much for watching us on Health is Wealth.